He told me in a very Texas way that if anyone tried to do that to him again, he would shoot them. Hi, everyone. I'm here today with Dominic Wilkinson. He's a professor of philosophy at the University of Oxford, and he's also a consulting neonatologist. Dominic Wilkinson, welcome.
Thanks very much.
So I wonder if we can start with some kind of bio. Can you tell us about how you got into where you're at now? What has kind of led you to the combination of philosophy and medicine?
Sure. So I have had an interesting, slightly unusual journey. I trained in medicine, subspecialized in pediatrics and then neonatal intensive care. And along the way, I'd always been interested in research. And there was a period of time where I was going to do a little bit of further study, and one of my mentors suggested that I do some ethics. Ethics is relevant for the clinical work, particularly in neonatal intensive care. So I went looking, and I thought I could pick up a subject, and then it didn't seem like it was going to be that much more to do a master's, so I thought I'd enroll in a master's. And I really enjoyed that and got very excited at the challenge and the stimulation of thinking hard about difficult problems and engaging in debate. So at the end of that, I thought I would potentially take that further and do a PhD. I'd been contemplating doing a PhD in a more usual medical sciencey field, but got attracted to do this. I went to Oxford to do a PhD with Julian Savulescu, and essentially since then I've managed to keep up a combination of clinical work and academic medical ethics. So
I'm wondering about how you balance those two things, like just in practice on a weekly basis, or maybe a monthly basis. How do you fit both of those in?
The practical way for me is that I have the university term in Oxford, which is about half a year or a little bit less than half a year. I'm full-time academic, and then the other parts of the year, which sort of fit in between, I fit in my clinical work. So I'm sort of on paper 50-50 clinician, 50% clinical, 50% academic. It's actually technically 60-60 rather than 50-50, which is often the way for people who combine more than one thing. So at the moment it's academic term time, so I'm not doing much in the way of clinical work. When the term finishes, I'll have to fit in some clinical weeks.
And so you work in an intensive care environment? That's the...
Yeah.
So what are the kind of main ethical issues that you are encountering on a regular basis?
Well, I guess the obvious ones that people think about in relation to newborn intensive care are end-of-life issues, decisions about when to stop attempting to prolong the life of an infant who's very sick or who has a serious and potentially untreatable illness, and questions about their long-term quality of life. There are very often issues about extremely preterm infants who might be expected to be born, and the boundaries of decision-making around extreme prematurity. So those are the kind of very standard. They're not exactly every day, because thankfully we're not every day having to grapple with those, but they're very common issues in newborn intensive care. And they have parallels and overlaps with issues in pediatric intensive care, where I've also done some work, and adult intensive care. Although my specific area of clinical work is neonatal intensive care, over time I've accumulated a fair amount of experience of how these issues are thought about in other areas of medicine.
So for me as a clinical ethicist, I've actually done very few pediatric or neonatal ethics consults, but I find that in general, I mean, most of the cases that I encounter are, it's pretty clear early on ethically what, at least kind of process-wise, what should happen, and then the difficulty is getting everybody to kind of agree to a plan or figure out what the kind of best way forward is, and then maybe 10% or so of the cases are ethically complex, where it's really kind of the ethics analysis. What's your experience with that kind of breakdown?
So I think it depends. It depends a lot on how many cases you're involved in as an ethicist. So I also chair the clinical ethics committee at the hospital, and in the UK, where clinical ethics I think is far less mainstream and far less developed than it is in North America, we see only the tip of the iceberg of cases with ethical dimensions. So the ones that tend to come to us tend to be the ones that are most thorny and difficult. And I often observe that it's the kind of nature of an ethical dilemma, or particularly the types of ethical dilemmas that come to us, is that there's no right answer, or particularly there's no good answer. There are only bad answers, and often it's a question of choosing between bad options. Some of those, it is, as you indicate, pretty obvious what the least worst outcome is, and there might be a question about how to get to there, or how to deal with the moral residue and the moral distress that comes with choosing an outcome that will have moral cost for those involved, often the patient and the professionals. I think there are a smaller number where it is the philosophical questions that you allude to are much more difficult, and where actually even working out how to think about the problem, or what how we might weigh those considerations is more difficult.
Yeah. So one of your papers I really like is it's on Schubert and the idea of a good death, and it resonated with me. You talk about hope in these kinds of end-of-life situations, and that I think that there's a balance. Like I often find that doctors I speak to are reluctant to say that there's little hope, or that it's hard for them to kind of really tell it straight to patients or to families, that could be difficult to have those conversations, and also for family members of patients who are making decisions, that there's it can be tough to just like accept what the kind of situation is. So can you tell me about like how do you see this idea of hope? Like how should we deal with these kinds of cases, or for you, I guess, as a person who's seeing these situations on a daily basis, and families are coming in, and this is usually the first time that they have to deal with these kinds of things. That how does the idea of hope come into what you do?
Well, I mean, I guess hope is complicated because it's partly an emotional response to uncertainty. One of the things that's very kind of easy for a philosopher is to step back from the emotions and to think about the reasons and the facts. But of course, when you're encountering the prospect of death as an individual, whether that's as a clinician or even more so as a patient, and even more so as a parent, you don't kind of encounter these as abstract facts or kind of calculations of utility. What you encounter are some fairly fundamental existential questions about life and death, and things that are just very difficult to accept. The possibility of losing somebody that you love, in particular. So part of the difficulty is about matching up and reconciling, to put it in a kind of everyday way, how we reconcile the heart and the head. How do we reconcile how we feel with what might be logical or rational? How do we cope with the reality that it looks like our loved one is going to die? How do we accept that in our heart, even if we know in our heads that that's the case. Well, in that paper and in my practice, one of the ways of responding to that is in a sense it's a non-philosophical way. It's to recognize the reality of people's emotional responses, so to acknowledge that that's very important to them, and to enable a conversation about those feelings, and then to talk in a realistic way about how we might hope in the face of what seems like a hopeless situation. How do we respond to that? And one way to do that is to talk about, as I often do in my clinical practice, about hoping for the best while also preparing for the worst. So when we face a situation where our loved one is going to die, or we're facing our own potential demise, what we might want to do is to focus on the small chance that we might recover or that the loved one might recover. But the language that I've often adopted, which comes from palliative care, of parallel planning, which is about having a plan for and hoping for the best case scenario, but also talking about and preparing for the less good scenarios, the worst case scenario, but sometimes even the ones between, is about, and that's about allowing parents, patients to hold on to that hope, but also allowing them to make preparations. And that, I think that can allow people to talk about things that they're hoping are not going to happen, and sometimes to make necessary steps towards that. So that's one response. The other response is to say that that hope is important, but sometimes what we hope for needs to change. So sometimes what we hope for we can't achieve, but there may be other things that we hope for as well. So when I talk with parents who have whose baby before it's been born has been diagnosed with a condition that's sometimes unhelpfully called lethal. It's a condition that's very, very likely to lead to the newborn infant dying. What may be natural for them to hope for is that the diagnosis is wrong, that the doctors are wrong, and when the baby comes out, the baby will cry and be perfect, and everyone will say, "Oh my gosh, how did that happen? We made a mistake." And that's very natural to want to hope for, and often I talk with parents and say, quite a lot of people who I meet in this situation, there's a secret hope inside their heart that says, I hope the doctors are wrong. And I can say, well, I hope that's the case too. I think it would be fantastic if your baby comes out. But is there anything else that you hope for? And so then we can have a conversation about what other hopes they might have. So which is that, well, if the doctors are right, they might hope that they get to meet their baby, that they get to spend time with their baby, that their baby doesn't suffer. And actually by allowing parents to articulate and hold on to what might seem from the outside like an irrational hope, the hope that despite all these repeated scans that everything's okay, by allowing them to keep on to that and to also talk about other hopes, the hope of meeting their baby, that their baby doesn't suffer, we can then move forward with making some plans for the care of their baby, if that does turn out to be the case. Now, all of that talk about hope, it's not very philosophical. It's not very kind of conceptually complicated. But in terms of dynamics, in terms of practical decision-making, it's incredibly important.
Yeah. So you've written about Schubert. What can we learn from Schubert about a good death?
So I wrote about Schubert partly because I love this piece of music, his Death and the Maiden string quartet, and I was interested in thinking about whether there was anything I could write that reflected on that. And when I went away and read about Schubert's the way that Schubert died, which was absolutely awful. So for those who are listening who don't know, Schubert almost certainly contracted syphilis, and at a relatively young age with tertiary syphilis, he was progressively deteriorating. He went away to the country to try and improve his health, but he spent his last days delirious, with little or no in the way of medical care, unable to eat anything. So he had an awful dying phase. And one of the reflections in the piece that I wrote about Schubert's life was, well, what was it that made that such a bad death, and how might we reflect on that for thinking about how we can make deaths better? When I work in newborn intensive care, I think there's often a desire for patients who we can't save to make their death good for them. And sometimes doctors in their own way can have a very clear and fixed idea of what would count as a good death, partly because we've seen lots of deaths and we've seen quite a lot of not very good deaths. And so we think we know what we would want for ourselves or for our family members. And so there can be a real desire to make death good for patients who are dying, and quite a lot of moral distress in cases where it looks like that's not going to be possible. So in the paper that I wrote, I talked about the different dimensions and sometimes incommensurable ways of thinking about what would make death good or bad. One very obvious way that was very bad for Schubert is that his death was full of significant unpleasant symptoms. And of course, we can make death good by providing good quality palliative care. In some of my other papers about end-of-life care and what might be desired or not desired, I've written about whether unconsciousness itself might be desirable at the end of life, and whether actually even more than standard forms of palliative care, which are about trying to preserve consciousness but relieve pain, whether unconsciousness might be desired at the end of life, and even anesthesia might have a place, perhaps particularly in jurisdictions that don't allow assisted dying, because anesthesia is pretty straightforwardly accepted as an ethical option, and if you could provide complete anesthesia, sleep, so many people express the idea that actually what would count as a good death would be to die in your sleep. So I think the idea that maybe you could offer people that option of falling asleep and then dying in their sleep without ever waking up, that might be an attractive way of dying. It might be a good death for some people. So that's one way in which Schubert's death was bad and could have been made better, and with modern palliative care we could clearly make that better. One of the things that's relevant for many of the deaths that I encounter in practice, that was not as relevant, I think, for Schubert, though some of the people who visited him in his dying days, and I think likely found that very distressing to witness, is the way in which deaths can be good or bad for those around the individual. So, and that is an example of a way in which the dimensions of goodness or badness of a death might go in the same way or might diverge. So what would count as a good death for the family might or might not coincide with what would count as a good death for the individual. So in some cases, what families want, for example, is for death to be prolonged or at least to be forestalled for as long as possible, whereas what might be best for the individual might be to accept a sooner death, or vice versa. So in some cases, families might desperately wish not that their loved one dies, but that the dying process is over as quickly as possible. But from the individual's point of view, actually they may no longer be conscious of anything. So there may not be anything bad in them slowly fading away over a long period of time, but that might be very difficult for a family to witness. And so that comes to a fairly familiar challenge in medical ethics, that there may be different stakeholders who have different priorities, and sometimes those can kind of compete or lead to an ethical dilemma. What would be the best way of managing the death of a child might be different for the child, or for the medical staff, or for the parents. And then, of course, you have to decide how to resolve that disagreement.
This is not so much a pediatrics or neonatology question, but I think most people, if we ask them, what do you want your death to look like, or what would a good death be for you, I think they have a clear idea about what that is. And then I think so often that is not what they get for many reasons. And so in a big picture way, what do you think are what are the main things that we could try to change to better align people's general wishes with what they have from the circumstances that we so often see with intensive care and so much invasive treatment at end of life?
So I think what you're alluding to is in particular that people might, in the abstract, have a desire for a non-medicalized death, a death in their home, a death in their sleep.
Planting out the cabbages, Julian Barnes, I forget who said that, but he quotes them.
Whereas what the way that many people end up dying is in hospital, sometimes away from family, receiving lots of medical interventions that might be significantly unpleasant, but have very low chances of benefiting them. Well, one obvious way we can help people to achieve the deaths that they would prefer is to enable them to articulate those preferences. So one of the reasons why people end up dying in hospital, receiving treatments that they wouldn't have wanted, is that they haven't necessarily had a conversation with their family members about what they would have wanted. And I mean, there's been a desire for many years to use advance directives as a way of trying to ensure that people's preferences are respected at the end of life. But there are a series of problems with advance directives, and very few people, myself included, have actually gone out there and completed an advance directive. One way of potentially achieving the same results is to support people to have conversations with their family about what their wishes are. And that might be more important in some ways than having a strict document that says that I don't want this or I do want that. And that's partly because of the problem that advance directives may not match on to the exact situation. But if you've been able to have a conversation about what things are important to you, what things you would want to happen, then your loved ones might be able to, in a more nuanced way, apply those at the end of life. So that's one important thing, I think, is to encourage people to have conversations, to have a think about what they would want. There are obviously also things that we could do as societies about supporting patients' choices. And obviously societies like Canada that make certain options available at the end of life can allow people to access those options if they would desire those. So access assisted dying, for example. In other countries like the UK that don't allow assisted dying, your choices are more limited by what's available. I think one of the other important things that we need to do as a society is to have conversations about what matters and what their options might be, so that people are enabled to reflect on what they would like. So, although you've suggested that most people would prefer to have the unmedicalized death while tending their cabbages, it's not actually universally desired. And some people have the opposite desire. What they want to go out fighting, and some of the ways that our societies depict death, or the way that people encounter death in popular media, on television, in movies, can reify or a medicalized dying. Give people an idea. Look, this is the right way to die. You die while having a code, while having everybody come and there's been for a long time a reflection that the way in which dying is portrayed in the media, or the way in which, for example, cardiopulmonary resuscitation is depicted, is very unrealistic. So there's a wonderful paper a number of years ago looking at the success rate of television CPR, which was vastly high. Most patients recover completely at the end of
playing chess right away. Back at it. Yeah.
Whereas the reality, of course, is the opposite, that most cases of CPR are unsuccessful, and that people don't get a sense, they certainly don't get the sense that medics do, that CPR is incredibly unpleasant, it's undignified, it's potentially painful. I was looking for it just last week because I was giving a talk to anaesthetists about end of life and dying, at the rate of rib fractures, which is about 60% if you have CPR, the rate of a flail segment, which means there's a whole bit of your rib cage that is sort of floating because you've got broken ribs in two places. It's about a third after CPR. Sternal fractures, so fracture of your breastbone, is about a quarter. So those are pretty bad things. Having had a few broken ribs a few years ago, they're incredibly painful. So that's a not very nice way to die if you're aware of any of that. That there's to go in a more often a more philosophical direction. There are interesting questions about what people's awareness might be of CPR, and there's a kind of imponderable problem of course, we'll never know what individuals might experience in their dying moments experiencing CPR, and it might be that they experience none of it, in which case you might say it doesn't matter. You may be aware that this is an interesting anecdote. A few years ago, there was a large study to investigate the phenomenon of near-death experiences, including the phenomenon of where people report having had an out-of-body experience, that they see themselves from above, they see the people resuscitating them from above. And in a study that I read for the first time, only very recently, though it was done a few years ago, there was a group who, in resuscitation rooms in hospitals, had put some shelves above where patients were resuscitated with some images on top of the shelves. And what they wanted to do was to interview people who'd been resuscitated and then to quiz them and to see whether any of them had seen these images from above the shelf they couldn't possibly have seen, to see whether these experiences could really be real. Now, as you might suspect, none of them were able to describe what those images were. There were very few who survived their resuscitation and who were able to report experiences. about 2% of those who recovered from their cardiac massage were able to report some form of awareness during their resuscitation that seemed to correlate with what actually happened. So a small number of patients are aware of CPR, probably at the potentially, including those who don't recover. And then, of course, we have to decide, well, what do we do about that? There's an interesting question, which is what I was asking the anaesthetist about, whether we should give patients receiving CPR analgesics during the CPR process. Almost nobody does. And the reason is partly because of a worry that if you give them analgesics, it might reduce the chance of recovery. And given that you're doing it to try and restore their circulation, that would be kind of counterproductive. But of course, if they don't recover, then you would want to make sure that they're not in pain.
Yeah. Yeah, when I worked in Texas, I met with a patient who had been resuscitated a day or two before, and he was one of the lucky ones that they were able to get him back quite quickly. But he told me in a very Texas way that if anyone tried to do that to him again, he would shoot them. And he just went through. I mean, he was intubated, like talking about the pressors, like he said he could feel it, and. It just sounded horrible. The last thing I wanted to ask about kind of on this neonatology is about, as you might know, Sick Kids, the children's hospital in Toronto. It's one of many sites that's doing research on artificial wombs or ectogenesis, which I know you've written about. In broad strokes, what do you think about this? What do you think are the kind of main ethics issues? And I guess I'm wondering, kind of like the tech is often portrayed as like, oh, we're going to have kind of a Brave New World scenario where we can just gestate embryos from day one. How do you see it going? How do you see the technology advancing?
So I think this is an interesting example where there's some really kind of profound and fascinating philosophical questions that are suggested by the evolution of this technology. And lots of the philosophical discussion of exogestation has kind of taken that possibility and run with it. So what would it look like for our society if we were able to gestate embryos in an artificial womb from early in pregnancy? What would it mean for abortion if a woman who at 14 weeks, instead of ending the life of the fetus, were simply able to transfer it to a womb? Would that mean for those jurisdictions that talk about the possibility of survival outside the mother's body as being significant for limiting mothers' access to abortion? Would that mean that actually the abortion thresholds would move backwards in time or even disappear entirely? So those are really interesting questions. They make philosophers excited to talk about, but they really frustrate the scientists because they're so far away from what they're talking about. And they really distract from the kind of questions of that are relevant to this particular technology. So just to explain when extremely premature babies are born 4 or 5 months, 4 months prematurely, getting even towards 5 months, their lungs are very, very immature, and the lungs are the kind of limiting step. What the technology has contemplated is being able to take those extremely premature babies, and rather than trying to support them on a ventilator, which damages these very tiny, fragile lungs, is to support them with something that looks like the physiological setup inside the womb with an artificial oxygenator that puts oxygen into their bloods, but that doesn't need them to be connected to a breathing machine. But technically, the way that it's done is to plumb by inserting little tubes into the blood vessels of this tiny half a kilo, 1 kilo baby, connecting them to a circuit that allows blood to go outside the body through this circuit back into the baby again. And there are kind of very fundamental sort of physics and technical limitations about that process that mean that it is, in at least to me, unimaginable that that's going to be possible much earlier than they're contemplating, or that we're able to support premature babies at the moment. What it might do, and raises some really interesting philosophical questions, is it might alter some of the questions around extremely premature babies and when parents might or might not have the option of choosing for resuscitation or not resuscitation for their extremely premature baby. It might adjust the borderline of viability a little, though I don't think it's likely to bring it back radically earlier in pregnancy. I think it raises really important practical ethical questions, which have got philosophical elements about. Here you've got a technology that's been tried in animals. At what point and how might it be tried first in humans? That's a really important question, on which I don't think there's an obvious answer. But these kind of more science fiction-y, Brave New World type questions, the more radical possibilities, are so far from reality that talking about them actually, although it's philosophically interesting, intellectually interesting, is really not very helpful. And actually it then confuses people when they're talking about what this technology might actually look like.
So I'd like to ask you a couple questions about the pandemic. I feel like every time I logged onto the internet, you had a new paper about something. So you were an early defender of challenge trials. You wrote about that in September 2020. You and colleagues wrote a lot about mandatory vaccinations and other things. So I wonder first, looking back kind of on that period and for how many different kind of things you had defending different views. Do you think now that you were wrong about anything?
Well, one thing, one general point is that there's a difference between being wrong in the light of the information that you had at the time and being wrong in the light of information that came subsequently. So for example, there were things about the virus that we didn't know at the start of the pandemic. So lots of discussion about kind of possible triage plans that might be needed ended up not being necessary because, for a variety of reasons, the actual impact in hospital didn't end up being quite as bad as people feared. So one question is whether the predictions or the kind of assumptions about the way the virus behaved or the way that people would behave were wrong. Another question is whether the kind of ethical conclusions were wrong even in the light of the information that was available at the time. And I don't think any of the conclusions that I reached I would move away from in the light of the information that we had at the time. Though I think hindsight's a wonderful thing, and
we learned a lot. Yeah.
I mean, one thing about the pandemic that's interesting to reflect on and sobering to reflect on is that in many ways we had a very mild pandemic. Now that might seem a shocking thing to say, but the characteristics of this virus were much less severe than many of the kind of proto-pandemics, the pandemic models that people were working from. So that's fantastic. That's great in one sense. But of course, the next pandemic, the pandemic that we're still waiting for, that WHO refer to as pandemic X might not have those properties. So we need to be cautious in thinking about the lessons that we might learn from the characteristics of this pandemic that we experienced for another one that might have different properties. One of the things I talked about with a number of other ethicists in thinking about what do we learn from this pandemic for the next pandemics is some colleagues in Japan were reflecting on earthquakes, kind of massive earthquakes. So they have a recurrent experience in Japan of very bad earthquake-related disasters. And each time they come around, people say, well, why didn't we learn the lessons from the last one? And so they made some observations that I thought were very interesting and then relevant for pandemics. So one is that preparation for earthquakes or pandemics is costly. So if you're going to, for example, have stockpile equipment, ventilators, masks, vaccines, or you're going to have lots of excess capacity in your healthcare system so that you can suddenly double your ICU capacity, that's going to be costly. It's going to mean for a lot of the time that's going to be wasted. And of course, we're all aware our healthcare systems, our budgets are always squeezed. So people can do that for a year or two, but then their memory fades, and people sort of say, "Well, look, we've got this big, we're wasting all this money on this. We need to just cut it back. We can't afford to do that." So that's one observation. The other is that people's memories tend to be short. That they remember it for a short period of time, but then it just gets. There are other things that crop up. There are other kind of really pressing problems in our world that we're struggling and grappling with. Whether those are the kind of enormous political challenges that many countries are facing, or the climate worries, that those things loom much larger than these other possibilities. The third thing is that the next time the disaster comes around, usually it's different in some important ways than the previous one. It's not just like the one that you had before. That would be easy in some ways, but usually they are importantly different. So although you've learned some lessons, they might not be able to be applied.
Yeah. I mean, thinking about in North America, so about challenge trials, about purposefully infecting people to study COVID in this case, that, I think bioethics took some hits. There were a number of bioethicists who were opposed to challenge trials, and in other ways, I think, now in hindsight, that defended views that I think were wrong. So what do you think are the main lessons bioethicists should learn from the pandemic?
I think there was a lot of very thoughtful engagement by bioethicists with different and opposing views in the ethical problems. I think one of the things that I learned that was disappointing was that it was very difficult to make a difference with any of those arguments or philosophical reasoning, and that was partly because, for the most part, we were on the outside. That the decision makers, the political decision makers in particular, in some parts of the world, in the UK and America, were a very long way away from those who were thinking deeply and hard about how we might respond to that. So that was very disappointing in some ways, because I thought that there were things that there were reflections and debates that weren't reaching those who were making decisions. Going the other way in terms of lessons for bioethicists, I think that one of the challenges of pandemics is that they occur in the real world in a kind of messy social and geopolitical context where things that we might think are obvious or ideal are just very difficult to realize. So one of the real challenges is to work out how and where to compromise on what we see as the obvious ethical answer in reflection of those. I mean, one of the ways in which we utterly failed was in global vaccine distribution, and that's an issue on which philosophically it's not difficult to think about how we might start to approach that, but politically it's very difficult to see how you move countries away from their insularity, particularly at a time of threat. I mean, the nature of threats, both economic, social, and political, is that people tend to look inward rather than looking outwards. They tend to be protective of themselves and their families rather than necessarily altruistic. So I guess the interesting challenge is how can we prepare in such a way that we can mitigate those weaknesses and problems? Are there ways to minimize those? One of the things that I reflected on in particular in relation to triage was that it was impossible for politicians at the time to kind of sign up to triage plans. It was just politically unacceptable for them to, certainly in the UK, to even contemplate putting their name to a plan that might choose between patients, even on the basis of something that seemed pretty intuitively important, which was saving the most lives in a pandemic. So one of the ways of trying to potentially move around that I encourage is the idea that we could, I mean, this is kind of obvious, that we might develop and sign up to pandemic plans in advance, that we might encourage our politicians to make plans in advance. And the reason that's politically advantageous, it's not philosophically very sophisticated, is that that they can sign up to plans in advance knowing that it won't be them at the time, and there's little political cost in signing up to a plan because it's all hypothetical, it's all on a piece of paper. And by the time it comes around, it probably won't be them. So somebody in the future can blame this past person for this plan that they've put in place because it was put in place. So it's a kind of buck passing between the present and the future, but in a way that's rational. So lots of buck passing is deeply irrational and problematic. We're going to push these problems to the future. They can deal with it. That's deeply irrational. We should avoid that. But sometimes we can push blame problems in a way that avoids people being trapped into making foolish decisions.
Yeah. So you trained in medicine first, and then you went into ethics later. So I mean, I did the opposite. I had basically finished my PhD and then started doing clinical ethics, and realized I didn't know anything about medicine. So what would you change about medical school or the way physicians are trained, with kind of an ethical lens?
I think that one of the things that's difficult for doctors, one of the problems that I encounter in clinical ethics is the sort of recognition that a problem is an ethical or a philosophical problem. So that often the clinicians will just encounter this as a kind of a medical or a clinical problem. So treatment is futile, for example. So to point to something that's fairly familiar to ethicists is that clinicians are inclined to think, look, it's just obvious that treatment is futile. This is something I can determine, therefore there shouldn't be any debate about it. And they don't recognize that actually there's a value judgment that's going on there. They don't sort of see what's going on beneath the hood. And so one of the things that I think is important it is hard to get into medical education is to recognise the value base of the decisions that we're making, and how those might be at least sometimes important to acknowledge and deal with in a different way. It's very difficult in a medical education system that's always pressured for time, and there's always more information that they need to absorb. But what we need to encourage and foster in our medical students and young doctors is the ability to step back, to be able to reflect on these elements of the problems that they encounter. I've certainly found in my own experience that it's particularly helpful for junior doctors to have a space where they can talk about ethical issues, and that's partly because they're encountering them in reality rather than in textbook case studies, so that they're much more significant for them, and they're really struggling with how to deal with these. They also, I think, have a little bit more headspace because they're not trying desperately to cram in all the information leading up to the exam. So I think that's quite a good time actually to enable ethical reflection and to foster some training in thinking through ethical dimensions of problems. But it does obviously need some underpinning in the medical curriculum, and I think that there's very obviously an important role for encouraging doctors to be aware of the values dimension, to be aware of the ethical dimension of medical practice.
What about going the other way? So what would you recommend for either philosophy departments or kind of bioethics programs how can we improve the way philosophical bioethics connects to the sorts of issues that are actually going on in hospitals?
Yeah, so a little bit like the conversation earlier about ectogestation is that one of the ways that we can that philosophers can become disconnected is if their suppositions or imaginings about how something works is just very far removed from how it either is occurring in practice. So one way of doing that is to creating some crossover, some opportunities for philosophers to be involved in clinical ethics committees, to see how real cases are what they really look like, and they're always much messier than they are in the textbook or in thought experiments. To have, but also potentially to be collaborating with clinicians in thinking about ethical problems or philosophical problems. So one of the things that I hope to do in my unusual split life as both doctor and philosopher is to try and use philosophy to support clinicians and medical thinking, to make it deeper and more thoughtful. But in the other direction, to be able to help philosophers thinking about kind of practical problems and to make them more realistic, more understanding of the complexities and nuances of real problems. So I think that we can support with creating opportunities for exchanges, collaborations, exploring the kind of interesting intersections.
Dominic, thank you very much for doing this.
You're very welcome.